Hello, I'm Martin Hamburg, and this is the second training video concerning Alzheimer's disease and related disorders of memory and cognition. In the first one, I tried to update you on our current understanding of the science of Alzheimer's disease. We've come a long way in about 5 years or thereabouts, and we know that Alzheimer's disease really begins decades before symptoms begin. And it's caused by a misfolded protein. In that regard, it's like a lot of other types of dementias, which has misfolded proteins that do tremendous damage to neurons. Interestingly enough, as we go through and understand the process by which Alzheimer's disease attacks the brain, it does suggest to us certain places that we might intervene, where we might essentially arrest that progress. And indeed, scientists are working hard to find medicines, to find vaccines that will arrest the progress of the disease and keep these misfolded proteins from doing the type of damage that they do. We're not there yet. But interestingly enough, we have in the process learned that certain things that we do behaviorally can slow down the progress of the dementia. Certain things that we can do in terms of our diet, in terms of our cerebral vascular health, and particularly in terms of our cognitive reserve, can first reduce the likelihood that we'll develop symptomatic Alzheimer's disease. And if you see some of the antecedent conditions of Alzheimer's, and I want to talk today a little about mild cognitive impairment, which for all intents and purposes we can consider as pre-Alzheimer's, that if we do those same things then, they can reduce our likelihood of getting symptomatic Alzheimer's disease. And once Alzheimer's disease starts, there are still behavioral things that we can do to slow down the progress of the dementia. Knowing that is good not only for our efforts to help people with Alzheimer's, but it forms the basis of how we can make sure that our therapy, regardless of what it is, it could be physical therapy, occupational therapy, whatever the type of therapy, is most effective. You need to know those things in order to be able to carry out those therapies effectively. And that's what today's video is all about. First of all, what I want to make sure you know about is there are really 5 types of neurological continuum that Alzheimer's affects in most of the proteopathies, most of these protein folding disorders affect, but they do it at different times and in different ways. Obviously, the first is memory. And we know that Alzheimer's affects memory more than anything else, and it begins by affecting memory. Now, it doesn't affect all memory, and we have to distinguish between what's called working memory and what's called reference memory. And there are some special types of memory, which is visual spatial memory. Working memory is memory that the time in which the memory is made is critical to its being effective, to you being able to use it. The example, of course, is where did I leave my glasses an hour ago? Where did I put them down? You have to remember the very time that you carried them, you took them into the kitchen, you put them down. That's working memory. Where did I park the car? In the shopping center parking lot. You have to remember the very time that you pulled in and where you parked it, otherwise you can't find it. Reference memory would be things like, which drawer do I keep my socks in? You might not have remembered when you made that decision, but you've used it many times. That's reference memory. Names of my children, that's reference memory. Clearly, Alzheimer's disease affects working memory much more than reference memory, except it does influence reference memory when it comes to spatial relationships, visual spatial memory. I want to tell you a story that happened to myself. My mother-in-law has passed away, and she passed away after suffering from Alzheimer's for a number of years. But before we really figured out that she was coming down with Alzheimer's disease. She was living independently. She was a very strong and independent woman, taking care of herself in every way, except that my wife, Sandy, began to notice that that there weren't that many groceries in the refrigerator. The refrigerator was a little bare. She noticed it one day and then didn't say anything. And then she visited again a week later and didn't seem to be an awful lot of food around. And she said, "Mother, have you not been feeling well? The refrigerator is pretty empty." Mother said, "No, I feel fine." She said, "Is the car okay? Is your car running well? Do you need to have some repaired under the car?" She said, "No, car is doing fine." She said, "Do you need a little extra cash? Do you have enough money? Is there any problem?" She says, "Oh, no, I have plenty of money." It took us about a week or so till we figured out and actually confronted Mother with the problem. And the problem was she was going to the grocery store and getting lost on the way home. And that was frightening her. So one of the first things you see, one of the early signs, is this visual spatial memory problem with Alzheimer's disease. When you talk to families, keep that in mind. When they describe what is happening to their loved one, look for signs that working memory is impaired and look for signs that visual spatial memory is impaired. The second thing, obviously, which we're concerned about is what's called cognitive function. And cognitive function covers a lot of things. It includes such things as being able to manage money, go to the store, be able to purchase things. And one of the things you notice is that some seniors begin to always pay for things in the grocery store with larger bills. So she goes into the grocery store and she buys a few items and it's $12.50, but she gives them a $20 bill. And it's much easier to give them a $20 bill than to take out of your wallet a $10 bill and 2 singles and 2 quarters to make of $12.50 if you can't do that calculation. Of course, then she accepts the change from the cashier and puts it in her purse again without counting it. And fortunately, most of the time, the cashier is honest and the change comes back. Of course, every once in a while, a cashier is not honest, senses the woman is not being able to count her money, takes the $20 bill and gives her back $2 when she purchases a bottle of milk. And if someone sees it, she just says, "Oh, I meant to give her a 10 and a 5 along with the $2 I forgot." But hopefully most of the time the cashier is honest, but she's having trouble calculating the change which is due when she makes a purchase. The other thing which we're really concerned about, and which is a cognitive function, is what's called executive function. And executive function simply means being able to do tasks in the right order to get them completed successfully. In other words, when we get up in the morning, we wash, take a shower, we dry ourselves, we put on our clothes, we go into the kitchen, we make a little breakfast, we put the dishes in the sink, and we leave for work. It's not good if you get up in the morning, put on your shoes, and then get in the shower, get out soaking wet, go into the kitchen, and try to eat your breakfast, then go back, dry yourself, and change your complete getting dressed. That's not the correct order. So we do find in certain types of dementia that the individual is having trouble sequencing tasks and getting them correct. Interestingly enough, in Alzheimer's, that's not generally that much of a problem. Though with some of our residents in our assisted living facilities, we always say things like, if you go into the resident's room and you can't find her socks and underwear, make sure you check in the refrigerator because that may be where she puts them. So basically, in her doing of her tasks, the wrong things get put away, not the food, but some items of clothing. Interestingly enough, in a situation such as dementia with Lewy bodies, which is the second most prevalent type of dementia after senile dementia after Alzheimer's disease, a loss of executive function is very, very common. And individuals have particularly hard time doing chores and tasks in the appropriate sequence to get them done successfully. The third area, of course, is what we might call emotional behavior and mood and affect. It's interesting that same type of patient who has dementia with Lewy bodies shows hallucinations, shows nightmares at night, and manages to have wild swings in emotion from one side to another. So individuals with certain types of protein folding disorders can show those. Most people feel that's not a prevalent sign of Alzheimer's disease, though it's interesting that many people with Alzheimer's appear depressed. And so the jury is kind of out whether depression really is one of the hallmarks of Alzheimer's disease. It used to be felt that Parkinson's, switching gears on you, that Parkinson's it did not have a component which was depression. Well, now we're quite certain that it does. The fourth area is motor control. And in the case of, let's say, again, dementia with Lewy bodies, there is a lot of motor control problems. As a matter of fact, dementia with Lewy bodies is sometimes referred to as a Parkinson plus disorder. In other words, it's Parkinson's disease with some things added on. Motor control is a serious problem with that. And the last, of course, is language. And indeed, Alzheimer's disease becomes a language disorder as it progresses to its final phases. And that produces some unique challenges as the individual with Alzheimer's ceases to communicate verbally. In things like frontotemporal lobar degeneration, and I just mentioned that in the first time around as probably the third most common proteopathy. That's extremely common in two parts. There is two types of frontotemporal disease. It's characterized by severe changes in language, as an example. Let's get back for a moment to Alzheimer's. Some people talk about the stages of Alzheimer's disease, and they talk about early stage Alzheimer's, middle stage, late stage. Those have never meant too much to me. I've always had trouble dealing with them. I really like the way Naomi Feil characterized the stages of Alzheimer's disease better. She talks about maladaptive, and then she talks about time confused, and then she talks about repetitive motion. And she does note that in its final phases, if an individual frankly lives long enough, they can go into a vegetative state when the degeneration finally hits the brainstem. But that, I think, is much more descriptive. And in fact, there are ways in which we can determine that and ways in which we test individual with Alzheimer's disease. Now, we probably will not be doing direct testing. But again, as you talk to families and you urge them to speak with their physician, and you urge them to try to understand what's happening to their loved one, you should know what makes up a good battery of testing. And actually, we may in fact do that on an outpatient basis with either psychologists or social workers. The most common test, of course, is the mini mental status examination. And it's probably the poorest of the three most popular ones, but it's the one that takes the least amount of time and the least amount of training. Clearly, the better ones are the ADAS, the Alzheimer's Disease Assessment Scale, ADAS. And when that was first created, there were two parts to it, a cognitive part and a non-cognitive part. They never were able really to fully validate the non-cognitive part, and it's kind of fallen into disuse. So everyone talks about the ADAS cog, which is what's administered. And the other one is the CDR, the Clinical Dementia Rating Scale, the CDR, which was developed at Washington University in St. Louis. So people generally refer to it as the WashU scale for Washington University. So there's mini mental status, the ADAS-COG, and the CDR or the WashU test. And these are a combination of direct tests and tests based on history. A lot of the diagnosis of individual with Alzheimer's disease is dependent upon the report of people who live with the individual's spouse or children. And they start off by saying, you know, mother's changing. She's just not the same. She's forgetting things. She's not knowing where she puts things. She's become irritable. So now you know some questions to ask to try to determine, is she having visual spatial problems? Is she having working memory problems? Is she showing changes in emotion? If she is showing changes in emotion and language and executive function, there are other things that should be tested for. And you can urge families really to get more complete testing in order to determine what's going on. In recent years, the term mild cognitive impairment, MCI, is really becoming popular. And what's meant by mild cognitive impairment is, again, something which is causing an individual to act a little differently and act a little strangely, but they're still able to carry on their everyday life independently. That's a critical part. It's frankly the proper description for when we say, you know, mother's getting a little senile here. She's getting a little forgetful. And we talk about amnesic type and non-amnesic type. And certainly the amnesic type is very predictive of developing Alzheimer's disease in subsequent years. And so more and more is being done now to understand MCI and to be able to start intervening and helping individuals with MCI at the earliest possible time. What can you do? What can we do to help individuals not only with MCI, but as actually they start entering into those phases of Alzheimer's disease? Sometimes what you're going to have to be doing is talking with the family and urging them to get full evaluation and to consider a placement in an assisted living facility. But nobody really wants to do that at first. They really want to maintain grandma at home as long as it's safe to do, and to give her the type of help that can be brought into the house. And of course, that's where we come in. The first thing that, one of the things that we become aware of is the fact that in the early stages, in mild cognitive impairment and in the maladaptive stage of Alzheimer's, the early stages of Alzheimer's, this is where, and now I'm going to give you a big fancy term, cognitive dissonance is the greatest. What's cognitive dissonance? It basically means an individual knows something's going wrong, but they don't know what. And basically they're becoming aware of their condition, but they are either in denial of it or it frightens them very much. And so this is often the time when various maladaptive, even aggressive behaviors come out. Again, within an environment such as an assisted living, this is when the resident says, you know, Mary, that nurse, comes into my room every night and she moves my glasses just for spite. She moves them from one place to another so I can't find them. Of course, what's happening is she has losing her working memory. She's losing her visual spatial memory. And she can't remember where she placed her glasses, but she's not ready to face that. She would rather accuse Mary. And when she looks in her purse, it always seems that the amount of money is not right. That she had more money, now she has less money. So who's coming into her room at night, taking her money out of her purse? Sometimes it's even much more accusatory that people are coming into her room through the window and basically moving things around, threatening her, and she is really frightened of people coming into her room. In all of these cases, you really have to what we call validate and redirect. Obviously, it's tempting to say to the individual, we'll call her Mary, Mary, you know that the nurse is not coming in and moving your glasses. You just can't remember where your glasses are. And the money in your purse, you bought some things yesterday when you went to the store. And that's why you don't have as much money as you had today. And nobody is coming into your room at night. In other words, we would like to take the individual with MCI, the individual with Alzheimer's disease, and kind of drag them into our reality. They're into their own reality. They're in their own reality. Doesn't work. And so what you really have to do instead, again, Naomi Feil was a leader in the field who taught us about validation method, and that you really have to first validate and then you can redirect. I should mention, by the way, that Naomi Feil has been in the field a long time, and she did come up with some theories about why individuals with Alzheimer's disease show certain types of maladaptive behaviors. And they were kind of psychogenic theories. And I don't think the field has embraced them that much. I think a lot of people have questioned them, and I don't think the evidence is there. So it's unfortunate that Naomi has a little bit of a bad name because of some of the theories that she's postulated, which are not accepted. But her method of helping individuals showing maladaptive behavior has been proven to be correct many times, and that is to validate and redirect. So instead of saying that you're going to, if you get an assisted living example, but you can make up examples at home, that the caregiver's coming in moving glasses, say, well, I'm going to check and make sure that doesn't happen. And I promise you, each night before you go to bed, I'm going to come in here with you and we're going to make sure we place those glasses in the same place. We're going to place them on the night table right next to your bed. So rather than allowing Mary to place them or any place in the room where she's certainly going to forget where they are, you develop a program where you make sure they are in place. Check during the night, double lock the window, etc., so that you validate what the individual is saying and then you redirect them. As people advance into other stages of Alzheimer's, and again, I'm not sure how much of this you're going to see at home. At a certain point, it's really so much better for individuals with Alzheimer's disease to be in assisted living, but some continue at home, and we, in fact, might end up doing home health care in assisted living environments. What is necessary in order to slow down the progress of the dementia are two things. One is continue to work on strong cerebral vascular health. Continue to try to give physical exercise as best you can. Put up people on a low-fat diet, Mediterranean-style diet. Prevent the continued deterioration of the cerebrovascular bed so that you can hopefully continue to clear the bad protein for as long as possible. The other thing you want to do is continue to replenish and build up the cognitive reserve. And to do that, you have to keep people active mentally and active socially. And one of the things you want to urge is that you go back in time to tasks that the individual can still do and to perform and to spend as much time in those tasks as possible. In other words, if you have a gentleman who is you're caring for him and he has perhaps the time confused stage of Alzheimer's, the middle stage of Alzheimer's, and he's losing his ability to do a number of tasks. Maybe when he was a youngster, he was a stamp collector. And maybe if you put a stamp album in front of him, get his loved ones to bring you an album and some cheap stamps, and you buy in a stamp store, he may spend hours matching up the pictures of the stamp to the picture, placing it in an album, and that's really very, very good for him. If an individual, I'm thinking of some of the people we had. We had one woman who had been a flight attendant for Eastern Airline. We were able to bring in all sorts of things from the old Flight Attendants Association. There still is one. They brought in pins and hats, and we had her set the table and to do various tasks as if she was setting for individuals on an airplane, and she was extremely happy doing those. And you could come up with a bunch of them. I remember for a while early on when I was becoming active in the Alzheimer's field, and we knew something about these things. We used to basically have an individual, Mary, help with perhaps the laundry. And she would help put all of the clothes in the dryer. And after they came out of the dryer, she would fold them very, very carefully. It took a long time. And after she finished that, about 20 minutes later, we could take those clothes and we would put them back in the dryer and tell Mary again that the clothes had to be folded. And she would come and she would fold them again. And some people would look at that and say, oh, that's terrible. That's cruel. You make her fold them and repeat them and fold them. She was very, very happy doing it. And in fact, her disease is slowed. I think you can do better than that. I don't think you have to have a person fold and refold the laundry. But before we knew some of the theory behind microenvironments and what it does to essentially keep the small oligomers of the plaque from taking up residence in insulin receptors, etc. Before we understood some of the biology, we knew that keeping people with Alzheimer's very active in tasks that they could still understand and perform was important for their happiness, and as it got studied more and more, actually slowed down the progress of the disease. So that's kind of the second thing. And the last thing I want to make you aware of is as you reach the final stages of Alzheimer's disease, as you reach, for instance, the repetitive motion, and you've seen these people clearly in assisted living facilities, and they're just walking around aimlessly. They don't know quite where they belong, and they are in a state of repetitive motion. You'll notice also that they are expressing themselves in very, very little language. Receptive language remains. Expressive language is the one that generally diminishes dramatically. But it's necessary to try to figure out ways to communicate with these individuals. And in fact, there have been several very good efforts. Joanne Konakost wrote a wonderful book called Learning to Speak Alzheimer's Disease, in which she talks about the types of ways in which you can communicate, initially with pictures and with gestures and ultimately with touch. It's clear that initially touch is probably not the best thing you want to use with individuals with Alzheimer's, but as the disease progresses, to basically reassure them is extremely important and satisfying. If you ever have an opportunity sometime to see within an assisted living, sometimes an person with Alzheimer's disease will come up to you and they'll say nonsense words. They'll say, Abba Linsanga, Abba. You have no idea what that means. Now, if you can try to pair it with what their needs are, you might be able to figure out what they're trying to express. But if you can't, and you repeat it to them, Abba Samba Alinga, I couldn't remember what I had said, and you say it in the same tone of voice and say yes, sometimes they are very happy about that, and they shake their head affirmatively, and they walk away very satisfied that they've communicated with you. So sometimes it's necessary to revert to nonsense language in order to communicate. In a therapeutic setting, when you're going into a home, I think it pays to try to understand what the patient is trying to say to you with the help of a loved one. And if you do want to begin to communicate, do try pictures. Do try essentially to give individuals choice between a milk or bathroom or rest by showing pictures and having them point to what they're interested in doing if you are the caregiver. So various types of picture boards are helpful, and mainly trying to decipher and understand what the individual is trying to communicate to you, even though language is in fact declining. The final thought I wanted to leave with you is obviously it's a challenge in order to initially determine what type of dementia you are looking at, what's beginning to develop. We're, as I said before, likely to see people in the very early phases where they're mildly cognitively impaired, where the family is more likely picking it up than anybody else. And they're saying, Grandma's doing some things that are strange. In which case you want to urge them to get more complete testing. And you know now some of the tests which should be performed. If they have no source of it, we'll help them find such a source. Do refer them to their doctors, but stay in touch, because so many doctors simply say, oh, well, we'll have to wait and see, and send them home. By the way, there are some diagnostics, PET scans, etc., which can, and certain types of MRI that can pick up the early components of Alzheimer's or other types of dementias. So they're clearly seeing a neurologist and getting appropriate studies done is probably worth doing. But then as the disease progresses, the trick is to continue to keep them as active mentally and socially as possible, hopefully instill good cerebrovascular health with exercise and diet, and stay one step ahead of the disease by knowing basically where it's going and how to keep people active mentally and socially. Of course, the question always becomes, when do you recommend that an individual with Alzheimer's disease seek care outside the home? And that's a very tough question. A lot of families want to keep them at home and have the capability of keeping them at home for a fair amount of time. But most individuals with Alzheimer's disease reach a point which they are going to thrive better when they have the type of care that can be gotten in assisted living. But all you could do is urge families to become educated so that they can, with the help of their health caregiver, make the best choice in those cases. That's the end of this training video.